This is a session partly about a particular project of evaluation of co-production, but it's also about a history of co-production of Signet that Dr. John van Niekerk will look at. And also we will have the development of Expert by Experience project within Signet. Saw a video by Raf Hamaiza, who is responsible for it, and Joanna Fox, who is Associate Professor at Anglia Ruskin, also with lived experience of mental ill health, and Joanna Griffiths, Research Assistant at Anglia Ruskin with lived experience, will also speak about their experiences. I'm going to talk about the use of photo voice as an evaluation tool with a particular group. Okay. Thank you for putting up my slides. I'm engaged in an evaluation of introducing new interventions method by staff members for a closed ward of women diagnosed as having personality disorder or borderline personality disorder. I am supported by Associate Professor Joanna Fox, that I've mentioned a minute ago, as well as by 3 people with similar lived experience and research knowledge: Joanna Griffiths, whom I mentioned, Rafa Maiza, and Alex Hunter. The women arrive usually at the ward under compulsory admission, mainly due to a high level of self-harm and at times also drug addiction. Often they are moved to a voluntary admission around the 3rd month and tend to stay for about 1 year before leaving for a community placement. The ward offers a variety of interventions aimed at improving their mental health state and reducing the rate of self-harm. Next slide, please. The innovative new interventions are very important, and their value is very important to find out because from both the perspective of the participant and the service provider, because the new intervention are not only time-consuming, but also, if successful, they would be applied to other similar units of the organization. The staff opted for 2 new interventions, which require staff being trained, as well as being ready to try very different interventions from those that they were applied before. These are dialectical behavioral therapy, DBT, offered both individually and in a group format, and shared decision-making concerning issues such as medication, decision about the transition process, and outcomes of leaving the ward. I don't have the time to explain what dialectical behavioral therapy to people who don't know, but just very briefly, I would say it was developed by a woman with personality disorder diagnosis, Marsha Lineham, in the 1980s. And it has proved, and it very much focuses on the one hand on compassion, developing compassion towards and with the service users, as well as developing self-responsibility. And it has proven very effective in terms of reducing self-harm. Shared decision-making is just what it says. I could spend the whole time just on that. Next slide, please. So these interventions are based on the assumption that the women patients are able to undertake self-responsibility for their decisions and actions. And for this purpose, they would need to be ready to give up behaviors which they have engaged in prior to coming to the ward, namely frequent attempted self-harm, very poor self-image, poor relationship with significant others, and poor use of their abilities. Hence, the staff decision partly represent the unhappiness of the staff with previous method but it's also readiness to take considerable risks with this highly vulnerable population by trying the two new methods. So PD, personality disorder, borderline personality disorder, or emotional unstable personality disorder are more frequent among young women than among young men, have a much higher prevalence in the population than psychosis, and previous method did not seem to lead to a high level of success. Next slide, please. So what is photo voice and why we have chosen it? Photo voice asks the people applying it to take photos of situation and people that reflect on the issue the research is focused upon. And the photos are taken are used to initiate a conversation about what they reflect concerning the person, situation, problems, key changes from the perspective of the person. Photo voice were selected as a method that enables openness, creativity, and control by the participants, while enabling an in-depth recorded interview to take place 3 times a year in 1 year to map changes taking place across the year. It also enables people less experienced in sharing their feelings in words to share them through photographs. And it is actually, this method is grounded in the critical pedagogy of Paulo Freire, not just in clinical mental health. And this particular pedagogy encourages critical examination of reality, looking at urging individuals to question and investigate underlying assumptions about the reality. Again, I could spend the whole time just on that. Next slide, please. The training, we had 2 face-to-face training sessions with the potential participant of 3 hours each. And in the training program, we gave examples of photo voice, including in mental health research. We explained the need to get people consent for any photos of a person, as well as choosing a pseudonym, which will appear in the recorded conversation. We never use the real name of people in any recording. And we ask participants to take photos of the garden at the bottom of the building in which the ward is located, and to share them with each other. In parallel, staff members have to write reports on how the women are doing in different activities every 3 months. So we have dual type of evaluation. Next slide, please. Here is one example. Millicent has written quite a lot on photo voice in mental health, and this is taken from a study in 2020 of Romanian service users' experience of recovery in mental health. And the photo which was taken by those people signifies a sense of hope and recovery. Next slide, please. This is the first slide of one of the participants in the study. I'm going to show you the 3 slides and then her explanation of their relevance. The first one is of her room. Each participant in the ward has a room to herself. When Joanna and myself visited the ward, we were amazed at the fact that some of the rooms were in total disorder, but they were not asked to put order, because this does enable them to really reflect where they are. And it's up to the staff, to live with that to an extent. And one way to see the changes is actually to see the change in the way the room is organized. This particular room, as you can see, is very well organized. I will mention some of the key elements of it when we look at what she said about the room. Next slide, please. Stop sign about the activity she would like to stop. Next slide, please. The geese, there are geese at the lake below, and they come to her to be fed. Whenever she comes, they recognize her. And again, I will explain what it means to her. Next slide, please. So, what do we learn about SG from her photos? SG are the initial of her pseudonym. And first of all, it's quite impressive how rich her room is. And one important element that she mentioned is of what her mother gave her before the mother took her own life. And the mother did it while she, the patient, the participant, was in hospital with a self-harm attempt herself. So we can just imagine how she feels about it. And as I mentioned already, that the room is very well organized, which is, I think, is also a reflection of her ability to put order and to have a sense of order and control when she wants. And the stop sign is about all of the barriers which come with her history. One which is full of not knowing who she is, that's how she describes it. The sense of being a failure, yet the knowledge that she has abilities and skills. She is actually a very good photographer and painter. The geese, whom I mentioned, come to her to be fed. They are the symbol of what she can offer to those who understand her readiness to give and her capacity to do so. And all of that came in the 1 hour interview. I didn't know much about her before. It was, I really was grateful that she was ready to share all of that. And now I look forward to our next meeting in 3 months' time, which is actually quite soon. Thank you very much for listening.
Just get our next speaker ready.
Thank you. So my name's Joanna Fox. I'm an associate professor at Anglia Ruskin University, also a person with lived experience, a co-researcher with Shula on the project. So I'm going to talk about a little bit about the interaction between myself as a lived experience expert and researcher interviewing women with borderline personality disorder on a closed ward. Next slide, please. So we know in many forms of research, particularly in quantitative forms of research, there's a focus on the objectivity of the research. Data needs to be reliable and valid, and it should be untarnished by the researcher identity. There's a focus on excluding researcher bias. Next slide, please. Yet moving forward now in more qualitative forms of research, we know that it's often recognised that the researcher identity does actually influence the research process, although some methodologies will talk about bracketing off the researcher identity, so enabling the researcher to reflect on what is them and what is the research. Although in some methodologies, particularly in peer research or service user-led research, there's a commitment to enabling the researcher to reflect on their identity and their influence on the research process. Next slide, please. Sometimes in social work, we talk about this as reflexivity, particularly around social work practice or social work research. And it's about understanding the values of the author, the researchers, their opinion and their biases, and understanding how this all being of the researcher impacts on the research and recognizing that it can either enhance or reduce the quality of the research. And there's somebody reflecting in the corner. So next slide, please. More and more in research, which is led by experts by experience, and I'm using here an example by Pinfold et al. In 2019, experts by experience, where they are involved in guiding and defining research processes, it's recognized that their lived experience can positively enhance and support that research process. They can be involved in research data collection, data analysis, and implementation of the research, and their expertise, their understanding, their perspective can enhance all levels of research. So next slide, please. And it can also reduce power imbalances. So in the training that Shula talked about that we shared with these women, I shared my lived experience as a person with a diagnosis of mental ill health. So slightly different to these women, a diagnosis of schizophrenia, but again, some shared experiences. So I shared a picture of my dog, my very naughty dog, who's now shut out of the room, so she's not barking. But when I'm stressed, Rusty comes, I take Rusty for a walk. So if I have too many emails, Rusty comes for a walk with me. When I'm at home alone and I'm overcome by all the emails, she comes for a cuddle, and I share all these things with the women. She gives me a structure to my day. So when I'm working at home, she helps me to break up my day with walks, to get away from the computer, to stretch my legs. She's also a source of my hobbies and stuff I actually do outside of work. And this was a real point of connection with the women that I interviewed. Next slide, please. So this lady identified herself, her pseudonym is Blue Dog, and this is a picture of her dog. So other women shared with me pictures of guinea pigs or rabbits, but I particularly like this picture of her dog. So Blue Dog talked about that her dog gave her a sense of purpose, in that when she was at home with her family, she felt a sense of needing to go for a walk. Her dog accepted her, it didn't reject her. And when she was at home, she felt a sense of belonging and a sense of being at home. So her dog gave her a sense that when she was at home, she could belong, she had a sense of purpose and a sense of acceptance. And we kind of shared these things and talked a little bit about that. And I think I called my dog into the room and showed a picture of my dog just as we were talking. Next slide, please. So these are shared moments of reflection. Again, when I put together these slides, someone commented on, do I think the women actually remember I have lived experience? I don't know. I wonder whether they actually appreciate that. But as a person with lived experience, I feel safe to share because I'm in a sense of strength and a sense of acceptance of my mental illness, my mental ill health, my experiences, my things that affect me. But what are the boundaries? And I have to be very aware of when it's helpful to share, and also to be aware that how much can I understand of the women's lives. So I talk about reducing power imbalances, but me as a researcher, someone who's an associate professor, who has an everyday job, how much of the women's lives can I actually really understand? There's some cross-linking of experiences, but how much of their lives can I really understand? And if I share myself as a person with lived experience, I have to think, does it reinforce their sense of failure or does it give them hope? And that's something that I deal with when I talk to these women, I think, am I helping them? Am I supporting them? So final slide, please, just some conclusions. So when I share experience with the women, it reinforces to me the need to be very gentle with people who may feel fragile. So maybe as a researcher, I probe less. I'm more mindful of body language. I can see if someone's losing confidence, losing attention, and I will back off. I try not to invade their space. Maybe sometimes I ask about the helpful things rather than the unhelpful things, the things that impact negatively on lives. So sometimes maybe it reduces my effectiveness as a researcher, but sometimes it improves my understanding with them. And I'm very clear to presume that I don't know about their lives, that their lives are very different to mine. But I hope that when I share photos, when I laugh with them, when I share pictures of my dog and laugh a little bit about Cocker Spaniels who bark during the middle of an interview, that we share in the commonality and humanity that we have. And I think that is so key to sharing lived experiences. So thank you. Thank you very much for listening. Thank you.
Thank you so much. That was beautiful. So our next speaker, I think they wanted to introduce themselves briefly. So Joanna.
Hi, my name is Joanna Griffith. I'm here to present a video from the Photo Voice research project my colleagues have just been talking about. The video is something I contributed using my lived experience of ill mental health, and it was played to prospective participants. I hope that it encourages others to think creatively about how they can include people with lived experience in their work. I think video, photography, art, music, movement, written and spoken word can all be amazing routes to better understanding people and their experiences. Thank you for listening, and I hope you like my video.
Very good.
Hello, my name is Joanna and I am involved in the research that we are talking to you about today. I have created this video so I can tell you a little bit about my involvement and also share some of my photos with you. I have lived experience of my own diagnosis of borderline personality disorder and have had various treatments for it. One of those included a long stay on a unit where I did lots of therapy with other people who had similar diagnoses. I am part of the team behind this research because I feel like it is a way that I can try and help people who have had similar experiences to me. When something is researched, a lot of knowledge can be gained and better decisions or changes to treatment can be made by taking into account how things directly impact us. Sometimes I feel like researchers don't ask people who have experienced mental health difficulties what they think about the treatment they are receiving enough. I think sometimes they will only ask the doctors, nurses, psychologists or other professionals, or sometimes they just look at data, which doesn't necessarily mean much to us. So, I'm really happy to be able to be part of this research and that this research is all about what you think. I hope it is reassuring to you that someone who has been in similar situations has tried to think about what might be important to you and how we can make it as smooth as possible for you to participate. When I thought about how photography is going to be used in this research, I tried to imagine how I would have felt in your position. Sometimes I have struggled with self-doubt, and I know I might have been wondering if I could...
Sorry about that. I will just fast forward to that moment.
...photos that were good enough, or if they were of the right thing. I might have questioned where to start and what use I could be at all. I wasn't very nice to myself. I know that this can be quite common when you are struggling with your mental health, so I want to reassure you, in case you feel that way, that the photos can be of anything that is meaningful to you. To emphasise this, I'm going to share some of my photos I took when I was in residential treatment and what they mean to me. The first photo here is of the building of the unit I stayed on. The building became my home for the duration of my treatment, and the name of the unit was tied up with hope and my expectations of getting better whilst I was there. In some ways, I felt it became a part of my identity because I was a little cut off from society whilst I was living by the rules of the mini society on the unit, including rules I didn't always agree with. The unit was where I belonged for that time. There were ways I had to exist there, and there were expectations for when I left too. So the photo represents lots of things to me that are both good and bad. The next photos are of me and some of my fellow residents and staff playing swing ball on the grounds of the unit and chilling in the lounge area. We had a group session timetabled each week where we could decide what we wanted to do, and we often chose to do some type of sport or sometimes gardening in the polytunnel, taking advantage of the sunshine when it was out. Exercise and physical activity became an important part of my recovery as I balanced some issues with self-image, my need to look after my body better, and develop awareness of how I felt physically and how it linked up with my mental state. It was both important and really difficult for me to develop connections with people during my stay. I made some great friends, but didn't always get on with everyone. Disagreements or challenges often came up in group therapy sessions, and it was useful to talk through what had happened with others and give myself space to think rather than skipping to judgment or self-loathing, as I might have done before. It was exhausting too, but I understood that that was one of the main reasons I was there, so something I needed to stick with. These pictures are some of nature on the grounds of the unit. These were really some escapism for me. Staying on the unit felt very full on, and I had to find ways to keep myself grounded and focused. This was especially true when other people were on different recovery journeys, which didn't necessarily match up with my own and where I was at. I suppose it was kind of mindfulness, just witnessing things I like to look at in nature. It gave me a feeling of being grounded and a bit of peace when treatment felt overwhelming. There was a little duck pond and lots of lovely plants, so there were loads of things I could take pictures of. I think the way I have taken some of the pictures make it look like I was in a different, maybe nicer place, probably reflecting the fact that I felt like I wanted to be in a different place sometimes. My final photo here is also of nature in the grounds, but this is one I connect to more emotionally. I have always loved the way plants like these create shadows on the ground. As someone who struggled to talk, I often wished I could hide in the shadows, and sometimes I suppose I behaved in a way which rejected other people trying to communicate. This was like having my own sort of prickly leaves, trying to protect myself from the hard work of learning to negotiate connection and manage the ups and downs of interacting more healthily with people. This one makes me laugh a little now, because looking back, I think I did manage to soften the prickly parts of myself, hide in the shadows less, and take what I saw as a risk in forming connections with people. It was one of the biggest turning points in my treatment, and something I can see that is so obviously different now to before I went onto the unit. I hope that these photos have been useful to see. Yours might not look anything like this, and I think that is the great thing about using photography and talking to different people. Everyone has a unique experience and understanding of it. You are the expert on you. I hope also that you know that if you take part, your input is so valuable to research. Thankfully, research in general is listening to the voices of people who have experienced things themselves more and more, but still not enough. So I hope that you know that in this study, your participation will be absolutely appreciated and respected. It will also be really useful. Thank you for listening to my video. I hope you enjoy taking photos, and please don't be afraid to ask the research team anything.
That's great. Thank you, Joanna. Thank you. Our next speaker is Raf, who also has a video, so just bear with me.
Hi, my name is Raf Amazia. I'm the Group Expert by Experience Lead for Signet, and today we're going to be discussing implementing co-production from a lived experience perspective. And we're really going to be touching upon some operational examples of how to do this. Often we talk about co-production as some sort of philosophy or some sort of concept that needs to be embraced. And I think in the early days, as we're kind of shifting away from more traditional forms of engagement, we had a long conversation, but I think there is that buy-in now, and the conversations really need to shift to those examples of how it's actually being implemented on the ground, and that's something hopefully we can run through today. So I've been working for the organization for several years now, really building up a lived experience workforce and really ensuring that the lived experience voice is heard at every level of the organization, really from a ward to board level. So that's locally with our managers, with our staff working on the grounds within wards, and also on a regional and a strategic level, all the way up to committees, boards, steering groups, so on and so forth. A big part of my role is overseeing the People's Council organisationally, which is a service user forum within all of our services that tend to be held on a monthly basis. And we also have a group of experts by experience, all who have inpatient lived experience, which is very important for inpatient services in terms of harnessing that appropriate, authentic lived experience. So we have a team of nearly 35 experts by experience, all who have been through our services or NHS services as inpatients, and they're representative of the service lines that they visit. So for example, eating disorder services would have someone with lived experience of being on an eating disorder service, and that's really important in terms of understanding some of that lived experience and then being able to provide that peer support in an appropriate and authentic, credible manner. So a lot of the work we do really as experts by experience is capture feedback. Sometimes we'll get feedback about not enough activities, sometimes we'll get feedback about food, and it's about how we translate that into co-produced initiatives to then enhance the service user experience. A good example is around meaningful activity and around the built environment. Historically within mental health services, the built environment can be quite clinical in nature. Wards can be quite medical. There's very much a focus over the years on infection control and all of these things, which is all right. But perhaps at least off-ward environments to begin with in many services which may not be more advanced in their thinking, can we start to change that conversation a little bit? So a big part of that has been building something called social hubs organizationally. And what social hubs really are is a co-produced concept where we'll go and speak to service users that have raised issues around the environment or activities, and then we will work with them in creating a wish list of things that they want, and we will basically order it in and we'll come and all fit it together in one day. So that's experts by experience, that's service users, that's staff, that's the estate, so the maintenance team, that can be contractors, that can be senior leadership and management. We have people from other organisations and NHS trusts sometimes come and support. the third sector, so charities, the local community, and really it's about everyone working together to try and ensure that we will make over a room in a day. So we will literally turn up and just transform a room once we have that wish list and everything's been ordered in. And the feedback that we've got from these rooms have been amazing because they're non-clinical in nature. You know, you get your video games in, you can play your FIFA, you've got your nice sofas. It's none of the kind of medicalized stuff because they are ultimately supervised areas. Access is individually risk assessed. And so this idea that someone can go off the ward independently, in essence, if they have unescorted Section 17 leave, for example, where they can leave the service and go into the community, why can't people go to a room? So, you know, I've never really fully understood that. And that's one of the things that has kind of been part of the business case, really part of the pitches. If someone can just go outside and walk into the street, why can't they go into a room off the ward within the service without all these risk considerations that we would have? We can individually risk assess things and ensure that people are able to be supported in the least restrictive setting. So some of the examples around how the social hub have actually impacted service user experience positively have been around engagement, particularly on evenings and weekends. Sometimes service users have reported that after the OT staff go home a little bit later at the night, or after activity coordinators go home, it can get a little bit boring, 8, 9, 10 p.m. and people just want a little bit of a space to kind of hang out in and have a chat. Also, the same goes for weekends. We have done other things to address stuff like that. For instance, looking at rotas around weekends and stuff like that, and that's had a positive impact too. But again, part of this co-production piece is not only looking at this one project, but about what we can do more widely, and that may involve multiple changes, and that's really important to remember. But the spaces have reduced incidents. Staff also say that they actually prefer to work in those environments because ultimately, if you're on close observations, for example, would you prefer sitting in a corridor, or would you prefer sitting in one of these fantastic rooms where you can kind of be engaging with people, playing games, watching a movie together, and just talking and catching up in a non-clinical environment? Another example has been around our work with food. So a big point on food really was that it was our number one concern for some time. I'm just going back a couple of years, and we've done a co-produced project looking at how we can improve food with our procurement department, who are very supportive, very responsive. And we went out, we spoke to people, and we realized that actually the chefs in our services, we've got nearly 200 services, but mainly focusing on our healthcare sites, a lot of them felt kind of isolated, should I say. They report to the individual managers of their service, who will have varying degrees of knowledge and competencies around food. And they really didn't have an opportunity to talk to each other as chefs from site to site. So we done a co-produced project that looks at how we can improve all of those things. And part of that was bringing everyone together. And we created something called Chef Development Days, where we bring our suppliers together with our procurement team, experts by experience, service users, staff, our chefs, and even the systems and manufacturers, so produce, people like Corn, organizations like Corn. And we'll basically all meet together, we'll co-produce different menu ideas, we'll co-produce different ways of cooking with award-winning restaurants from the local communities, and just have an opportunity to network, share ideas, share best practice. We also created a group chat where we have all of our chefs in with our suppliers. So where there are issues that come up around supply chains or logistics or ordering, that can get dealt with a lot easier. But also people now create a little bit of healthy competition, because you've got people posting lots of stuff in the groups on a daily basis. And it just creates a little bit of healthy competition, because one site will be like, hey, look what we did today, and everyone's like, that's great. And for the chef as well, it's like, you're getting a little bit of feedback and you feel part of a wider community like that as well. But also it promotes and incentivizes other chefs to also take that leap of faith and work with service users better, improve the quality of food, and also get that recognition and that support, and to be able to showcase organizationally. We now do those events quarterly, and where we bring everyone together And since then, we've seen significant increases in food satisfaction. I mean, it's gone from one of our main concerns to really not being a concern at all. You know, we still have occasional feedback here and there, but nothing out of the norm. It's the last I had checked, which was only a couple of weeks ago, we're hovering at the 7th or 8th position in terms of the areas of feedback, and out of 10, which is pretty good. So we're talking over 75% increase in food satisfaction if you was to try to quantify it. And that's really positive and a good example of how co-production can have a positive impact in the space of just a year and a half. Other examples are about embedding music therapy within services. We've got a co-produced project called Music to Empower, and that's all about creating recording studios. Music is the oldest form of therapy for people experiencing mental distress, and we kind of provide resources. We shoot professional music videos for people within our services who have lived experience but want to express themselves through music. And again, that's been amazing. We've seen people kind of get played on BBC Radio off the back of it, people going to employment after discharge in the community, and so many more benefits. We're currently doing a project at the moment around music and faith, and that includes virtual reality and basically, you know, multi-faith rooms can sometimes be like a prayer mat and, you know, some holy books, which is very great and really important. But there's nothing like really being able to go to your place of worship, right? Going to a mosque or a synagogue or a church or a temple. But sometimes people can't do that, right? If you're detained on a mental health act, you haven't got Section 17 leave, it's really difficult to be able to do that. And sometimes it's even out of our clinicians' controls, the responsible clinicians, if people like the Ministry of Justice are involved, right? So what we're trying to do is, it's not a perfect solution, but it's making things a little bit better, hopefully, is to provide a virtual holy experience. So if you are in a service, you can kind of tune in virtually to a mosque or a temple or a synagogue. It might not always necessarily be a live session, although that is being explored as part of the pilot we're currently doing. It is also about looking at, you know, kind of virtual experiences and pre-recorded kind of sermons and so on. And we feel that that's going to have a really positive impact from the feedback that we've got working with our experts by experience and service users and the community and religious faith leaders from the outset. So those are some of those examples. On our website, we have a co-production hub where you can basically go and fact check me on everything and make sure I haven't been waffling for the last 10 minutes. So go on to our Signet website under service users, families and carers, you'll see co-production at Signet. Then you'll see different hubs for things like Music to Empower, and the different initiatives that I've spoken about today. And I would really urge you to go and look at some of those examples, see people's talents, see what lived experience and co-production brings to the table and how it changes cultures of organizations. And whether it's the digital world, whether it's finance, whether whatever it is, everyone can play a part in supporting co-production organizationally, and hopefully some of the examples that I've spoken about have been able to raise awareness around that. Thank you very much for having me.
I'll just prepare John's slides.
Great. I do wonder, Becky, I've got quite a lot of slides with very little time. So I'll do a very quick introduction. So I've worked with RAF now in our organization, but also through the Royal College co-production steering group. And this is a steering group we set up in the college, and we brought people from outside of the college in. So people from Rethink, people from all over the NHS and organizations to share best practice about where they've implemented co-production. And it is really a paradigm shift from the sort of traditional biomedical model, really to make sure that we include everybody to come and share how they've brought the patient voice to the fore and how they've reduced those the power imbalances that exist implicitly in a lot of the professional relationships. And what we saw was really privileged to see all the fantastic work that is happening around the UK. But at the same time, we felt it's great to see these pockets of excellence, but how do we get everybody to buy into this? How can we sort of make this the standard that, you know, no hospital is designed without carer or patient input, that the way people access care in the community should be shaped by the communities that use it. And we heard earlier today about people being excluded or the frustrations in accessing care. So we wanted to go and have a look at, well, where do people do this well? Where do they get it right? And from that, we've created a repository to influence guidance of how do you go about doing this? If you're at the beginning of the process, how do you mature that? If you're in the middle of it, and so on. And because we've so sold on it, because I think it's one of those things, once you allow co-production to really not just a buzzword, but once you actually do the work, and it does take a bit more time, the consultation and the working, but once you do that well, you don't want to go back. It's something that actually, once you've worked in that particular way, so we've recently designed a new hospital with the clinical and the patient and carer voice shaping it, and you just prevent so many things that you then later have had to put right if you didn't do it. So that element of co-design and co-production is now so in our DNA, I can't see us ever turning back. I'm not saying that everything is perfect. We still have a long way to go, and that's why we're interested in this research that Shula's leading on, and Joe, because we want to make it even more, have that patient voice even more. The next slide, please. And the next, I think if we go to slide 3 or 4, the next one. So these were just the events we had, this slide. So it was interesting, we talked about thinking like a butterfly. The transformation that occurs and why it's happening and why I think co-production's time is ripe is there is a big shift to a more social perspective in mental health. It's definitely there in the policy. We want to see it now in practice as well. But it's influenced by a lot of different things. Society is changing. There isn't this deference to medical expertise that there used to be. Knowledge and medical knowledge is much more freely available because of the internet and other things. And there's also, I think, an increase in service user expectation to how things were before. So you can see there's a sort of philosophical shift towards value-based and person-centered approach. What frustrated us is that the rhetoric is there. There's a lot of beautiful words, but where's the action? Where can we actually see how this looks like? But it does feel like co-production's time is here. I think if we can go to the slide about what's in a name. So the slide there was just about the benefits. Actually, there's quite a lot of evidence now that the co-production, when you work in this way, when you work in this collaborative way right from the start, that it enhances patients' health and well-being, it increases patient satisfaction, it actually strengthens relationships, there's improved outcomes. There's all of this research that showed us it lowers readmission rates, it reduces stigma and prejudice. There's all this beautiful research and tells us that it is actually there, but it's not. It definitely is still very much in pockets, and you have to go and find it. And what we would like to see is that it's obviously everywhere. Next slide. So despite all of its benefits, there's lots of barriers that get in its way. And what our research looked at is, okay, so how can we break through these barriers? What can be done to actually make this everywhere? And the next slide, one of the first problems is its name. So co-production means different things to different people, and there hasn't actually been a universally agreed definition. So we as a group set up to come up with our own definition by involving carers, patients, people from right across the ecosystem to get that, so when we do research on this, we're very clear about what we mean. The next slide. So this is the definition we came up with. So co-production is a collaborative process and/or relationship that enables individuals from all walks of life to share power in a meaningful way right from the start. Now, there will be different variations of this, but we felt this captured it. And we based our work on the following values you can see to the right. And within this space where there's a lot of polarization or people struggle, tweeting, you can't really have a conversation on social media, and I've yet to see someone change their mind. But what this allowed is it was a space that we created. I think it's a brave space that we created, where we kept each other to these values. And there was grace, there was listening to each other, real, not just listening, till you stop and then I speak, but real listening and understanding of the experience of the different individuals, including the professionals and those that use services. And the very interesting thing that came from that is the shared vulnerability. And when people can actually understand how the system is driving a lot of the behaviors, when patients and service users can understand what the professionals are facing when they're trying to change things, or the culture that inhibits, it actually created a lot of mutual empathy. And when the professionals heard the struggles and the difficulties that service users were going through, it created this shared vulnerability, created trust. And it was through that trust that we were able to tackle some really difficult subjects, some wicked problems that are within the mental health system. And I think that we came up with some really good suggestions and looked at examples as solutions and ways forward. I think if you can maybe go to the last slides, because I think we're probably so there's lots of barriers. I'm not going to go through those. You might be familiar with these anyway. Risk assessments and the sort of risk-averse practice and so on. I wanted to just stop with this slide because we spoke a little bit about this before, and I think it's the elephant in the room. One of the things that keeps us from moving forward with a lot of this innovation and working in this more creative way and reducing the power imbalances is fear. That's the elephant in the room. And I love this quote from one of the participants I interviewed. We've all been operating from a place of fear for such a long time. We're frightened. We're frightened of saying the wrong thing, doing the wrong thing. It's very everything feels very risk averse, and so there's many reasons not to do something. And so when we're operating from that space of fear, it's exhausting. And actually just keeping control and actually what we found when the service, when the professionals, when the managers let go of a lot of that, actually that's where the beautiful things happen, and that's where the patient voice can actually change your service to be more effective, to be more and all the other things I already mentioned. The next slide. If you carry on, sorry. Next. So this is just the theory that came out. One thing I would note, if you notice in the middle on the left-hand side, the sort of engine, the secret sauce, what made co-production powerful was when we were able to use of shared vulnerability and creative engagement. Once that happened, and it was supported by leadership and a sense of belonging, it was sort of a virtuous circle that developed. And actually moving forward, people, once they've experienced working in this way and people were able to open up and share and trust, it tended to lead to more things, and it sort of proliferated throughout certainly our organization, but also other organizations that we looked at. Next slide. And the next. So again, here's a quote about exactly what I just spoke about. It means taking back and taking in the vulnerability that we might struggle with, particularly doctors. So doctors or psychiatrists, there's this idea of omnipotence and being put in a position where you're dehumanized. So although the patients in the system complain a lot about dehumanization, we also see it with professionals. So these things are projected onto you as if you can see into the future, as if you, the sort of powerful persona, which is a false persona, is created. And what we tried to do through the shared vulnerability was the horizontalization of relationships, was actually saying that the professional is also a fallible human being working in a system that is broken. And that created that empathy to understand why certain interactions have occurred. And it was really powerful thing to sort of think about rehumanizing our doctors and our psychologists. As working within the system. Next slide. I've spoken about this, but yeah, so it at its core, co-production challenges the traditional hierarchies by advocating for a redistribution of power and recognizing that expertise does not lie just with the professionals, but is shared amongst all stakeholders. This is a profound shift, and it requires to let go of control and embrace a more egalitarian approach. You can stop sharing the slides now because I know we're running out of time. I would just end with some hope. I was just this week in meetings where the Culture of Care, it's an NHS England commissioned, a big piece of program. It's in every mental health trust. Is looking at making risk formulation into something that's more like a safety formulation and safety planning. And that work is ongoing. And it's really lovely to see a lot of this stuff is proliferating into the different systems. And like I said, I feel co-production's time has come, and it is now important that we make sure that leadership is everywhere, and it happens not just in pockets, but is distributed so that everybody can benefit from this very new philosophy, way of working and paradigm. Thanks. Sorry, I felt like I wrote some of that.
It's beautiful. It's beautiful. And